Hello and welcome back to another episode of Taking Control of Cancer. I'm Steve Bland and this is the podcast from the North East London Cancer Alliance that helps you, where possible, take control of cancer. And this one is all about checking your prostate cancer risk. We're recording this episode on World Prostate Cancer Day, and we're exploring one of the most important ways to improve outcomes for men with prostate cancer, and that's understanding your risk and getting checked as early as possible. This is our second episode recording from Goodman's Field Medical Practice here in Whitechapel. And I'm joined by Dr Bunmi Olajide. Bunmi, you're a GP here in North East London, and I'm told a passionate advocate for raising awareness of prostate cancer, particularly among communities at higher risk. Welcome, Bunmi.
Thanks, Steve. Thank you for having me. Yeah.
Well, fantastic. Thank you very much. And welcome back to the podcast to Rishi Athwal. Rishi, you are the Early Diagnosis Project Manager here at the North East London Cancer Alliance, and it's not your first time on our podcast.
No, second time now. I'm a veteran.
You're a veteran. You become a veteran after 2 times, I think. Thank you both very much for joining me. We've done episodes in the past about prostate cancer. I think it's a topic, particularly in this part of the world, that we can't talk about enough, isn't it, really? Let's talk about World Prostate Cancer Day, because that's where we are today, June the 11th. Every cancer has its own day, doesn't it? But why is this one so important, Bunmi? It's a really important topic.
It is. It's literally just looking at prostate cancer and how it's affecting men. The figures are there. And if we take the UK alone, we know over 60,000 men. Currently, it's about 64,000 men are impacted by prostate cancer each year, a diagnosis. 12,000 deaths a year from prostate cancer.
Right.
And we've got roughly about 540 men who are they've been diagnosed or are living with the disease. So it's huge, and it is the most common cancer in men. So there should really be a day for prostate cancer.
Yeah, very important, Rishi. And it's a cancer that's particularly in the news at the moment, isn't it? We're talking lots about government decisions on who gets to be screened and maybe more importantly who doesn't get to be screened. Some news last week. I think the recommendations that were made end of last year are going to be taken on board, which means only a small cohort of men, I think, are being screened. Whereas the big charities, a lot of people, wanted all black men, for example, possibly even all men. Eventually that might be the outcome that we go for. But it's a cancer that keeps us plenty to talk about when it comes to prostate cancer.
Yeah, absolutely. I think, we were certainly awaiting the decision of that, the decision from the National Screening Council around who should be screened for prostate cancer, with the recommendation coming back that it's just men with the BRCA gene and family history, whereas we thought it potentially could have been slightly wider. Absolutely, it's good to hear at least the recommendations are moving forward with that, whilst we've got trials ongoing as well, where we may well be able to gain some evidence, I guess, for how the best approach for screening going forwards and whether we can include a wider cohort of men.
Yeah, that's the Transform trial I think you're talking about.
Absolutely.
A really important piece of work. And I think, while maybe the disappointment was that not as many men as was wanted by a lot of people are going to be screened, there was more money for the Transform trial, wasn't there? And that's really important, Bunmi, because it's a trial, and you'll know more about it than me, but it's a trial that could, really inform how best to screen men going forward.
I think just as the name sounds, I think it's going to be a trial that would transform really what we do about prostate cancer, and that's going from kind of screening, investigation, management, everything that has to do. It is a huge study, £42 million committed, and the government just early June have added an additional 18 million to cover kind of research and look into how it impacts black men So 60 million, it's the biggest of its kind around the world, and we're really actually looking forward to kind of what results or what answers this trial gives us.
We've talked before a lot about the stat that we keep repeating. Around about 1 in 8 men will get prostate cancer, but that's around 1 in 4 when it comes to black men. Do we know why that is, Bunmi?
Good question, Steve. I think there are a number of factors that are considered. Exactly why that is, it is difficult to say. I think we know there might be some genetic predispositions, certain genes, and definitely that's been looked at. But exactly why that is, it is difficult to say, and we're hoping that this trial also gives us answers in that aspect. Yeah.
But in a really diverse part of London, Rishi, that makes it a really big issue for you guys here.
Yeah, absolutely. I mean, we know the sort of ethnic diversity that we have in Northeast London, and that's why it's really important for us as a Cancer Alliance to be able to make sure we're raising awareness of the risk, the additional risk factors that our community has, essentially. So, we've been doing lots of work to be able to do that and essentially give people the information that they need to understand their risk of prostate cancer.
What are the challenges when it comes to getting people to be diagnosed as early as possible? Because it strikes me that if you went, outside perhaps on the street here and you did a straw poll of 100 people, I'm sure many would know to look out for lumps, for unexplained bleeding. Perhaps they'd link a cough with lung cancer maybe. But I would suspect if you asked 100 people for the symptoms of prostate cancer, there wouldn't be that many that would know. So, firstly, kind of what kind of things should we be looking out for? And then secondly, what work is going on to really, push home those messages?
So talking about symptoms, you're right. For certain conditions, people can talk about lumps and bumps and feeling this way and feeling that way. For prostate cancer, we know there could be situations where there's no symptoms. Surely with early prostate cancer, in a lot of cases, there are no symptoms. And it's difficult enough to get men to go see their doctors. It then becomes even more difficult for men with no symptoms whatsoever to go see their doctors.
Yeah.
But when there are symptoms, then usually it's to do with the urinary tract. So it would be things like either getting up to urinate more frequent than usual, particularly nighttime getting up to go urinate, what we call urgency, kind of you feel you want to go and you have to go immediately. It could be hesitancy, where the man feels, I need to go to the toilet. They get there and then they have to kind of wait before it then comes on. So there are urinary symptoms. There are things to wash out in the urine. So if there's blood in the urine, or even in some cases for men, if there's blood in their semen, that should trigger some discussions with the doctor. And finally, I always touch on where there's no urine symptoms or something in the urine, but if there is erectile dysfunction. So we know there are all the varied causes for erectile dysfunction, but prostate cancer could be an early warning sign around that. So if it's new onset, particularly young fit male, I think it's always worth having a discussion with your GPs.
And if and if there is this kind of challenge around recognizing symptoms, and a lot of these symptoms, I'm presuming you probably only get, or you maybe only get symptoms when the cancer is a little bit more advanced. Do you see people, as a GP, do you see people typically a little bit later than you'd like to?
Yes, I do. And before I go further on that, it's just what you mentioned about symptoms presenting at a later time. And yes, we've heard this being said, and yes, it does happen in some cases where it's quite advanced by the time men start having symptoms. But we shouldn't take away from the fact that actually men could have symptoms even with early disease.
Right, okay,
So
yeah.
it's not losing hope to say,
Yeah,
now
yeah.
I've got symptoms, that means my cancer is advanced. So just on that. But we would love men to present earlier. Late presentation, we know generally there are factors. One we've already mentioned about just being men. It's difficult to say why we just don't like going to the doctors. I think for ethnic minority groups also is really things as simple as how settled they might be in the environment, and for those even brought up here, is kind of that trust in the health service generally. GP appointments can be difficult, and for all men, irrespective of ethnicity, it can be a put off at times if you try once or twice and then you kind of put it off. So those factors are there. Rishi talked about kind of in a northeast London area, we know one huge risk factor also is deprivation, and studies are clear about seeing more advanced or late-stage cancer presentation in men from deprived areas. It's actually a 29%
Wow.
chance that men in deprived areas will present late compared to those from the affluent areas. So, it's very the factors here.
Rishi, how much does family history matter? Because that's something we've talked about a lot when it comes to prostate cancer. And it's not just, your family history, it's actually understanding what your family history is as well. Because I'm sure not, not everybody perhaps would know, what a grandparent died from or even if that was relevant to prostate cancer, because there's plenty more cancers that are related to prostate cancer, aren't there?
Yeah, absolutely. I think family history is certainly one of those things that increases your risk. So if you have a brother or a father who's had prostate cancer, and correct me if I'm wrong, Bunmi, but also around breast cancer as well can have an impact in terms of family history.
Yep, breast cancer, ovarian cancer, and pancreatic cancer. However, we say linked to the BRCA2 gene mutation.
Absolutely, yeah. So it's absolutely key, really. And we know that one of the challenges around family history is sometimes it's not recorded very well. So if we're actively trying to seek out those people who may be at higher risks, it's often not recorded too well on GP records. So it makes it difficult for us to actively find them. So it's one of those things that we just sort of want to raise awareness of, really, so people understand that should they have people within their family that have had these cancers, that it's important to then, especially if you get to a certain age, have that conversation with your GP, present early, and see whether it's the right time for you to maybe then start thinking about, whether it's a PSA test or what the best approach might be.
Let's talk about PSA tests now you've mentioned them. The whole screening process, I guess, Bunmi, kind of what if you are lucky enough to qualify for it, what does the screening process involve? What's a PSA test?
Okay, so the PSA is a special protein that's produced by the pancreas. The PSA is a special protein produced by the prostate.
Yeah.
And the levels kind of then tell us if we should be worried about something going on with the prostate. The thing with the PSA is it's not specific for prostate cancer. So you can have a raised PSA and it's not cancer. So it could be an enlarged prostate or an infection in the prostate, or even something like an irritation of the prostate. So someone has gone on a long bike ride, rigorous bike ride before a PSA test, you could have raised levels. So it is not specific. And I think that's where the debate comes in. Importantly, in the scientific world, is that bit around PSA doesn't tell you that cancer is necessarily going to be the cancer to kill the man. So there's all this talk around mortality. The pathway has changed in that sense with the PSA. What we know is the PSA is the gateway for diagnosis as we have it in the UK now. To have a prostate cancer diagnosis, at some point that man would have had a PSA test. And in the old pathway, pre-COVID, it was a PSA test requested by the doctors, and if the PSA test is raised, the man is referred to the hospital, and what they do then is the biopsy. And so they have to take a lot of samples from the prostate. And in those days also, they go through the back passage, what we call transrectal. So there's a risk of infection, and that's where things like sepsis comes into as part of the risk. The modern pathway post-2019 is actually much better. And what you have is there's a PSA test, and if it's raised, that man has an MRI, a multiparametric MRI. And that can help check to see are there kind of suspicious area of the prostate to say this person might have cancer. So already that is screening some of the men. And then if a suspicious area is found, biopsy then is more kind of focused because you know where to go for the biopsy. And the other thing about the biopsy now is transperineal, so you're going through the perineal area rather than from the back passage. So risk of infection and sepsis is much less. That's the process generally for men, and it's much better. And I think the fans coming from kind of the big charities and actually even some group of clinicians is to say, yes, we know the PSA is not the ultimate test. The worry, for example, with the National Screening Committee is one, with evidence, but two, also the risk of harm to men. What the big charities and some sectors are saying is now the pathway is MRI and then biopsy, and even treatment changing to situations such that men don't necessarily have to have a treatment. They could decide to wash and wait.
Yeah.
So those advances are there, and those sectors now are saying, well, that risk of harm may not be as much as it was before.
I think it takes away possibly, some of I imagine one of the barriers is an embarrassment, isn't it, of what you think an examination might be, but you've explained that the process is a lot different now to what it was, going back a few years, and that's, sounds like that embarrassment kind of reason or excuse isn't really there anymore.
Yeah, absolutely. I think anecdotally we certainly heard from people that the sort of the previous method of doing things with the sort of lots of people thinking that if they're going for a check, it's going to be a rectal examination. Whereas, this, as Bunmi's described, is just a much different pathway these days, and it does take away that embarrassment and sometimes that stigma that's associated with it as well. So, I think it's important for us to make that clear, really, and hopefully that encourages more people to sort of come forward and engage in the process. Yeah,
definitely. We love a little bit of myth busting, and that's an important one to bust, isn't it? Because it's as you guys say, it is very different to how perhaps it used to be. Who can ask for a PSA test, and who currently qualifies for screening? I think you've mentioned the BRCA2 gene with a family history. Those are the people that qualify. Is it over 45?
Over 45, between the ages of 45 and 61,
Yeah.
with the new guidance. So they have the BRCA2 mutation with a family history of either prostate, ovarian, breast, or pancreatic cancer.
And who can just ask for a PSA test? If, is there a certain age group or certain category you can just walk into your GP and said, I just want a PSA test?
If we're going by the prostate cancer risk management program, any man over the age of 50 can ask for a PSA test. So the guidelines talk about, they present to the GP and they have a discussion around the pros and the cons. And if the man's happy to go ahead, then they can be offered a PSA test.
As we said at the start, we're at Goodman's Field Medical Practice today. And they've got an event talking about prostate cancer, haven't they? It's World Prostate Cancer Day, as we said. Bunmi, you popped into the room before you came in here. What sort of thing are people coming here with? Is it just a general interest? Is it a specific concern? Is it other men who just know nothing about this topic and want to be educated a little bit? I know you're only in there for a short time, but what kind of thing were you finding out?
Yeah, I was telling Rishi as I was coming in, so interesting, it was one of the men that came in and they've had urinary frequency, so they're going frequently to pass urine for a number of years. And it was nighttime impacting their sleep. But they hadn't discussed it yet with their doctor. And so what he said was he'd come in, he knew there was going to be a program, and he'd picked up one of the leaflets and had seen, if you're peeing more, maybe there's something there. And so he had a discussion.
I've actually got one of the leaflets here. I'm just showing, is something peeing you off or pissing you? I would say pissing you off. And there's some stars blocking out some words. We can say it. Is something pissing you off? I've got a bleep button if we need it afterwards. He saw one of these leaflets and he came along.
And he came along and it was that quick discussion with him, and now he's going to make an appointment with his doctor.
Do you think we'd have to go in there and ask everybody in there, but do you think people are coming, Rishi, with just a bit of a fact-finding mission, or do you think people, these opportunities are for people who have something niggling at them that's been, something maybe like this chap who's been having trouble for a few years? I wonder kind of what motivation there is for coming to an event like this.
Yeah, I think certainly it's people who have seen something like that and it's given them the information to be able to come forward, so they know in the background that they're having this issue. But unless sometimes you get a leaflet like that or some information that links it to something that you then just tells you it's something you should probably just go and get checked out, have a conversation around. Sometimes that's the trigger and that's the motivator that you need, and I think that's why a lot of the work that's being done. So, for instance, this campaign, a lot of the things that we're doing at the Cancer Alliance as well, and the charities are all doing as well, is it's just really key to just give people the information that they need to be able to have the confidence to have some of those discussions. Because sometimes it is just the tiniest little trigger that you need to have a conversation that could, it could have a huge impact on your life, really.
It's we talked with Toby in a previous episode. Toby's a GP here, and we were talking about the kind of role of the GP in all of this. And one thing that we sort of didn't get into, but we talked about it afterwards, was the kind of challenge sometimes of getting a GP appointment, what the options are for the online forms you can fill in. Talk Bunmi from a GP's perspective about, kind of your contact with men, more generally perhaps than just prostate cancer, your contact with men in general, why it is that you think that we are so reluctant maybe to come forward sometimes with different symptoms, and the options maybe if they do find it hard to get in touch with their GP.
Yeah, my experience is yes, and then you can see that even from a normal practice day. Just if you're looking at how many men actually come in on a good day, it's a good question, and I think it's a question we will keep asking around why men don't just present. I think there are some factors if we're looking at prostate cancer. Obviously, because it has to do with what a lot of men consider defines a man. It's the prostate, and it's a secrete place there. And so coming forward to talk about it can be really difficult. For some people, it's just the stigma around it to say, I know for some men, they think about prostate cancer and think about the complications that can arise and also maybe complications of treatment. And we know one of it, for example, is erectile dysfunction. And so they almost automatically equate prostate cancer to erectile dysfunction, and that builds some kind of concerns or not wanting to talk about it. Men, I don't know. I don't think it's only men because everyone's busy, but it seems for some reason we just kind of want to go out, provide for the family. And
I think we're more willing to use busyness as an excuse. I think that's what it is. Like, we're no more busy. We're probably less busy if we're being very honest, but we're much more willing to use it as an excuse. Paul, who is the communications and engagement lead at the Alliance here, he was talking about a great comparison. He said he was trying to get Oasis tickets, and you'll happily sit on the phone for 8 hours. But if you phone your GP and it's immediately unavailable, you're like, right, well, I've done that. That's ticked. I won't try that again. I'll just tell my own psyche that I've done it. And I think that's the kind of thing with a GP appointments, isn't it? That we're like I said, we're no more busy, but we're just happy to kind of satisfy ourselves either that we've tried.
And you touched about kind of looking for the Oasis ticket, men also with sports. If we're going to plan a football match or a cricket match or anything, we would really focus. But I think is that bit about what you're doing well now, raising awareness. Because I tell my patients, for example, the only way to contact your GP is not via the telephone. That's not the only way. Surely men can go online and online booking. And the patient I spoke to today, he was telling me about how good the practice is. He goes online and he gets an appointment quite quickly. For clinicians on our part, I think with the understanding we've got around men not kind of really presenting readily, what we can do is make sure that every contact counts. So if that man's made that effort to book that appointment, we just maximize that period to make sure we kind of get everything from them, but also give them that reassurance to make them feel, next time you can actually come back, and that helps.
And on top of the challenge of getting men to the GP, Rishi, you guys have got the cultural challenges, the inequalities, the diversity in this part of the world that we've touched on a little bit before. But what specific challenges do they bring in terms of getting people into the door to see Bunmi in the first place?
Good question. There's quite a few. So we've got challenges around language. So for instance, if we're trying to raise awareness of something like this, then we need to make sure that we're doing that in a way that is understandable for the community across North East London. And the amount of languages that are spoken in North East London is huge, in different communities. So it's about just trying to make sure that we're raising the health literacy, I guess, of all of those different communities, through doing things in languages that they can understand, but also in the way that we design things as well that's going to catch the eye of those different communities as well, so they can see themselves within our campaigns. that just sort of helps us to engage with them, really. I mean, we do a huge amount of events, things like coming to this event here today and speaking to different members of the community as well, and letting them know about our work and promoting all of the different things that we can offer. But it is a huge challenge because it is such a diverse population, and also it's a population in North East London as well that moves about a lot as well. So sometimes you'll have people within the area for, be it a year or 2 years and then move on somewhere else, and sometimes they're just passing through. So to be able to make sure we try and engage these people within that time, I think it is very much about that. It may only be one thing that triggers it. So if we can make sure, even within some of our communications out to people, that trigger and that contact is something that engages them and that gives them the information that they need in a language they can understand, it's just really key.
But you are doing plenty of work in this area, aren't you, to raise awareness, improve early diagnosis of prostate cancer here in North East London. Just tell us about some of the work you're doing, particularly your latest project.
So we're just about to start a project in the next couple of months, really, which is working with GP practices. So we have done a big dig of all the data across North East London and looked to try and find those men that are at higher risk, have a look in terms of where they're located across North East London, and essentially trying to find those men. So with a family history that's been recorded, as we mentioned previously, it's not recorded so well. So those numbers are relatively small, but also, as we've mentioned, so black men who have that higher risk. So we've done a bit of a dig into the data, found out the areas where those groups of people haven't had a PSA test within the last 3 years, and we're essentially trying to directly target them through the GP records, and provide them with a bit of context about what we're doing, but then provide them essentially with the information that they need to be able to make sort of an informed health decision. So do I need to talk to the GP, or just give them the knowledge of their increased risk, essentially. So there'll be a link to the Prostate Cancer UK risk checking tool, so they can go on and do that themselves. There'll also be a link to our website, which has got huge amounts of information on there as well. And then we'll be able to essentially track from there how many people we've reached, and whether those people have then gone on to book GP appointments as well. So it's that big piece about trying to raise awareness, particularly in the absence of a screening program. It's just making sure that people are aware of their risks and feel informed to be able to actually have that conversation with their GP if required.
In terms of treatment of prostate cancer, and we've talked in different cancers before about the importance of early diagnosis, but in terms of prostate cancer and the treatments that are available, how important is catching it as early as possible?
Catching it as early as possible increases the treatment options available, and really prognosis, the chance of cure is higher with catching it early. So the options available to the man is not then limited. We know with prostate cancer, men could have treatment ranging from radiotherapy to surgery, to focal therapy, where treatment is directed into the prostate to minimize kind of effect outside the prostate, and that could be through sound waves or actually radiotherapy that is also quite specific to the prostate. And there is even active surveillance where knowing that for some of the cancers, they might actually not kill the man or through their life. They can be kind of just observed. That man is observed. They have routine scans, and so an early diagnosis gives those options with treatment. Late diagnosis, we know the options are then more limited, and if it's very late and it's spread to kind of other organs, then the options are also further limited. So
just to wrap up, what are the things that are going to change, shift the dial when it comes to prostate cancer? What do you want to see in the next 5 or 10 years? We've just had the National Cancer Plan, haven't we? There's lots more money going into, as we said, the Transform trial. There's lots of talk about screening. What is it that's going to really shift the dial in terms of prostate cancer? Just, a couple of thoughts to finish.
I think one, having a definite screening program or screening pathway, which is definite, well established, that would transform things totally for men. And it could be the PSA with some other tests, or it could be a new test that kind of, once it's done, yes, it's definitely prostate cancer. It's definitely the aggressive one. The other thing I would love to see is kind of innovation in treatment. So we talk about risk of harm to men, and I think some studies look at about 12 in 1,000 suffer some form of harm from treatment. Innovations in treatment that helps minimize those harms will be great.
Yeah.
And part of it that is happening already is kind of trying to do more focal treatment and things like that, or just observing and not going in straight to treatment if it's not aggressive type. But innovations in treatment to minimize the risk of harm to men, that also would be one thing that I would love to see in the next 5-10 years.
Rishi, what are your I was going to say Christmas wishes, and we're nowhere near Christmas. We're in June. What are your wishes when it comes to prostate cancer?
Well, I think, certainly we're excited about what the Transform study might give us. I think, as we mentioned, it's absolutely huge, biggest in the world. So hopefully that can give us some clear indications around what the best method for any future screening program might look like. I think in the meantime, it's really just key for us to keep doing what we're doing, keep increasing people's awareness, keep trying to get people into their GPs, and some of that myth busting as well. But I think until we get some of those innovations, until we get some of those results from Transform and sort of enact some of that, we really just need to keep making sure people are aware of what the risk factors are and what the treatment options are as well, and then hopefully we can start just slowly making the early diagnosis numbers a little bit better.
Yeah, it's fantastic work. And, this event today, if you get, 20, 30, 40, 50 men through the door, you're probably going to find a couple that have got, reason to come and see you or their GP. And then you might, just add it, a couple of men here and there, and you start build the picture up, and the word starts to spread, and that's how it grows, isn't it? And lots of amazing work going on. Thank you so much, both of you.
Thank you,
Thank
Steve.
you.